This is Chapter 17, Respiratory Emergencies. Your national standard competencies for medicine applies to the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely ill patient. Respiratory, we're going to cover anatomy, signs and symptoms, management of respiratory emergencies, including those that affect the upper airway and lower airway. The anatomy, physiology, pathophysiology, assessment and management of epiglottitis, spontaneous pneumothorax, pulmonary edema, asthma, chronic obstructive pulmonary disease, environmental industrial exposure, toxic gas, pertussis, and cystic fibrosis, pulmonary embolism, pneumonia, viral respiratory infections, and obstructive restrictive disease. Dyspnea is difficulty breathing. It is a complaint that you will often encounter, a symptom of many different conditions, from the common cold and asthma to heart failure and pulmonary embolism. Several problems occurring at the same time may contribute to a patient's dyspnea. Whether or not you can determine the cause, you may still be able to save a life. Keep possible medical problems in mind as you obtain a history and perform a physical assessment. Regardless of the cause, the sensation of not getting enough air can be terrifying to the patient. You will need to treat the symptoms, underlying problem, and anxiety caused by dyspnea. Your anatomy and physiology review. The respiratory system consists of all structures that contribute to the breathing process. The upper airway includes all anatomic airway structures above the level of the vocal cords. Gas exchange is the process by which the oxygenated blood from the pulmonary circulation releases carbon dioxide, resupplied with oxygen before it enters the cardiac circulation and occurs at the level of the alveoli. Pulmonary circulation begins at the right ventricle, where the pulmonary artery branches into increasingly smaller vessels until the pulmonary capillary bed surrounds the alveoli and terminal bronchioles. There's substantially more circulation to the lung bases than there is to the lung apices. Most infections and pathologic conditions occur at the base of the lungs. This figure shows an enlarged view of a single alveolus or an air sac. The figure on the left illustrates pulmonary circulation, and the figure on the right compares respiratory systems of a child to those of an adult. Respiration, the principal function of the lungs. There are two processes that occur during respiration. You have inspiration, which is inhaling, and expiration, which is exhaling. Ventilation is the process of moving air into and out of the lungs. Oxygen entering the alveoli from inhalation passes through tiny passages in the alveolar wall into the capillaries. The heart pumps oxygenated blood throughout the body. Carbon dioxide produced by the body's cells returns to the lungs in the blood that circulates through and around the alveolar air spaces. Carbon dioxide diffuses back into the alveoli and travels back up the bronchial tree and out the upper airways during exhalation. Carbon dioxide is exchanged for oxygen, which travels in the opposite direction. This figure shows the exchange of oxygen and carbon dioxide during respiration. Oxygen passes from the blood through capillaries to tissue cells. Carbon dioxide passes from tissue cells through capillaries to the blood. In the lungs, oxygen is picked up by the blood and carbon dioxide is given off. Inspiration. The stimulus to breathe comes from the respiratory center in the medulla. The involuntary control of breathing originates in the brainstem. Impulses for automatic breathing can be overridden to a point by voluntary control. The motor nerves of respiration are the phrenic nerves and intercostal nerves. During inspiration, the diaphragm and intercostal muscles contract. The combined actions of these structures enlarge the thorax and cause intrapulmonary pressure to fall below atmospheric pressure. Normal inspiratory reserve volume is about 3,000 milliliters in a typical adult male and 2,300 milliliters in a typical adult female. Expiration. As the chest expands, mechanical receptors in the chest wall and bronchioles send a signal to the apneustic center via the vagus nerve to inhibit the inspiratory center, and expiration occurs. This feedback loop is known as the Herring-Brewer reflex. It terminates inhalation to prevent overexpansion of the lungs. Normal expiratory reserve volume is about 1,200 milliliters. Expiration lasts twice as long as inspiration. This relationship is expressed by the inspiratory-expiratory or IE ratio. Expiratory phase is short in a patient with tachypnea. Tables 17.1 and 17.2 list the characteristics of adequate and inadequate breathing in your book. Pathophysiology. For the body to receive the required nutrients and oxygen and dispose of waste products, adequate ventilation, diffusion, and perfusion must occur. Multiple complications can interfere with an ample intake of oxygen. Upper airway obstruction caused by foreign body obstruction, trauma, or inflammation such as tonsillitis or epiglottitis. Lower airway obstruction is caused by trauma, obstructive lung disease, mucus accumulation, smooth muscle spasms, and airway edema. Chest wall impairment is caused by trauma, hemothorax, pneumothorax, empyema, which is a pleural effusion, a pleural inflammation, neuromuscular disease such as multiple sclerosis and muscular dystrophy. Neurologic control problems are caused by brainstem malfunction from the central nervous system, depressant drugs, stroke or other medical neurological conditions, trauma, and neuromuscular disease. By rapidly assessing the patient and providing the necessary interventions, problems associated with oxygenation and ventilation can be minimized or avoided. Regardless of the reason for breathing difficulty, you must be able to immediately recognize the signs and symptoms and how to respond. You must know how to respond. Table 17.3 lists key signs and symptoms to help you recognize and differentiate between different respiratory complaints. Gas exchange interface. It is helpful to think of alveoli as small balloons at the end of a straw. Alveoli are made up of two types of cells. Pneumocytes is the name of those types of cells. Type 1 is almost empty, allowing for better gas exchange, and type 2 make new type 1 cells. It produces surfactant, which reduces surface tension and helps keep the alveoli expanded. Alveoli functions best when kept partially inflated. By reducing the surface tension of the alveoli, surfactant makes it easier for them to expand. After foreign material gets into the terminal bronchioles and alveoli, it typically never comes out. Collapsed, fluid-filled, or pus-filled alveoli do not participate in gas exchange. Conditions related to ventilation, perfusion, or both can prevent oxygen from reaching the bloodstream. Pulmonary capillaries are narrow and normally allow red blood cells to pass through only in single file. People with chronic lung disease and chronic hypoxia often generate a surplus of red blood cells over time, which makes their blood thick. Right side heart failure, because of chronic lung disease, is known as cor pulmonale. Carbon dioxide retention and hypoxic drive. The level of carbon dioxide in the arterial blood can rise for many reasons. Various types of lung disease may impair exhalation process. The body may produce too much carbon dioxide temporarily or chronically, depending on the disease or abnormality. If arterial carbon dioxide levels rise slowly to an abnormally high level and remain there, the respiratory center of the brain may work less efficiently. The failure of those centers to respond normally to a rise in arterial levels of carbon dioxide is a result of chronic carbon dioxide retention. The hypoxic drive is a condition where the brain gradually accommodates high levels of carbon dioxide and then uses a backup system to control breathing based on low levels of oxygen rather than high levels of carbon dioxide. The stimulus to breathe is the detection of low blood oxygen levels. If the arterial level of oxygen is raised, there is less stimulus to breathe. Giving too much oxygen to these patients may actually depress or stop respirations. Never withhold oxygen from a patient who needs it. Hypoventilation. When the lungs fail to work properly, the body cannot efficiently dispose of carbon dioxide, and it accumulates in the blood. Excess carbon dioxide combines with water to form bicarbonate ions and hydrogen ions, also known as carbonic acid, resulting in respiratory acidosis. Acidosis can occur if hypoventilation is not recognized. Impaired ventilation can be attributed to a variety of factors. Those are listed in Table 17.4. Carbon dioxide level in the blood is also directly related to pH. Hypoventilating patients have respiratory acidosis. As their carbon dioxide level increases, their pH level decreases. Many types of problems can cause patients to hypoventilate. Conditions that impair lung function or conditions that impair mechanics of breathing, obesity, hypoventilation syndrome, respiratory compromise related to morbid obesity, or conditions that impair the neuromuscular apparatus. This could be serious injury to the spinal cord, the Guillain-Barré syndrome, amyotrophic lateral sclerosis, botulism, which is caused by the bacterium Clostridium botulinum. Also conditions that reduce respiratory drive. Hyperventilation, overbreathing to the point that arterial carbon dioxide falls below normal. This may be an indicator of life-threatening illness, and it's the body's attempt to compensate for acidosis, buildup of excess acid in the body. Lowering carbon dioxide helps to compensate for the other acids. Tachypnea without physiologic demand for increased oxygen causes respiratory alkalosis. Alkalosis causes symptoms of hyperventilation syndrome or a panic attack, including anxiety, dizziness, numbness, tingling of the hands and feet that can lead to carpopedal spasms, and a sense of dyspnea. Hyperventilation can be the body's response to illness and a buildup of acids. Hyperventilation syndrome is not the same thing. This occurs in the absence of other physical problems and common during psychological stress. Causes of dyspnea, shortness of breath or difficulty breathing. There are many different medical problems that may cause dyspnea. If the problem is severe and the brain is deprived of oxygen, the patient may not be alert enough to report shortness of breath. Altered mental status is a sign of hypoxia of the brain. Patients with the following medical conditions often experiencing breathing difficulty or hypoxia. Those are pulmonary edema, hay fever, pleural effusion, obstruction of the airway, rib fractures, cystic fibrosis, hyperventilation syndrome, prolonged seizures, neuromuscular disease, environmental or industrial exposure to toxic gases, carbon monoxide poisoning, and drug overdose. As you treat patients with disorders of the lung, be aware that one or more of these situations most likely exist. Gas exchange between the alveoli and pulmonary circulation is obstructed by fluid in the lung, infection, or collapsed alveoli, that is known as the atelectasis. Alveoli are damaged and cannot transport gases properly. Air passages are obstructed by muscle spasm or mucus or weakened by floppy airway walls. Blood flow to the lungs is obstructed by blood clots. Pleural space is filled with air or excess fluid, so the lungs cannot properly expand. All of these conditions prevent the proper exchange of oxygen and carbon dioxide. Pulmonary blood vessels may also have abnormalities that interfere with blood flow and the transfer of gases. Besides shortness of breath, a patient with dyspnea may also report air hunger. The patient reports not getting enough air and a strong need to breathe. Chest tightness is described as an uncomfortable feeling in the chest, commonly reported by patients with asthma. Dyspnea is a common complaint in patients with cardiopulmonary disease. It may be caused by physical exertion, made difficult because the heart is damaged. Congestive heart failure results in blood not pumping efficiently, leading to breathlessness. Pulmonary edema is associated with congestive heart failure. Severe pain can cause a patient to experience rapid, shallow breathing without the presence of pulmonary dysfunction. Breathing deeply may be a sign of pain that is due to expansion of the chest wall. When assessing a patient for complaints of dyspnea, ask about chest pain and ask about dyspnea when evaluating for chest pain. Upper or lower airway infections. Infectious diseases may affect all parts of the airway. Infections that impair airflow through the airways are problems of respiration. Infections may cause dyspnea by obstructing airflow in the larger airways as a result of the production of mucus and secretions. Infections may also impair exchange of gases between the alveoli and capillaries. Table 17.5 shows infectious diseases that are associated with some degree of dyspnea. Acute pulmonary edema is accumulation of fluid in the lungs, causes a decrease in gas exchange, and results in severe dyspnea. Severe myocardial damage caused by an acute or chronic problem results in reduced contractile force of the myocardium. The left side of the heart cannot remove blood from the lungs as fast as the right side delivers it. In pulmonary edema, fluid collects in the alveoli and lung tissue. The fluid separates the alveoli from the pulmonary capillary vessels. It interferes with the exchange of oxygen and carbon dioxide. It may develop quickly, especially following a major cardiovascular insult. Not all patients with pulmonary edema have heart issues. Other causes include poisonings from smoke, toxic chemical fumes, or other pulmonary irritants, traumatic injuries of the chest, and exposure to high altitudes. Patients with pulmonary edema that is cardiogenic in origin may present with signs and symptoms of a cardiac emergency. Patients with non-cardiogenic pulmonary edema tend to have a history of associated factors, including hypoxic episodes, shock, chest trauma, recent acute inhalation of toxic gases or particles, or recent ascent to a high altitude without acclimatizing. All patients with pulmonary edema may also present with dyspnea, orthopnea, fatigue, reduced exercise capacity, or pulmonary crackles. Chronic obstructive pulmonary disease, or COPD, is a common lung condition. It's a slow process that disrupts airways in the alveoli. COPD is an umbrella term used to describe a few lung diseases, including emphysema and chronic bronchitis. Cigarette smoking is the most common cause. Obstruction occurs in the bronchioles. The cilia are unable to remove excess mucus, creating a buildup. Chronic bronchitis results from overgrowth in the airway mucus glands and excess secretions of mucus, which blocks the airway. Patients have a chronic productive cough for at least 3 months per year or 2 or more consecutive years. Pneumonia develops easily when passages are consistently obstructed. Repeated episodes can lead to COPD. Emphysema is the most common form of COPD, degenerative condition characterized by destruction of alveolar walls related to the destruction of pulmonary surfactant. Large holes are left in the lung that resemble an air pocket or cavity. It is an irreversible condition. Most patients with COPD have elements of chronic bronchitis and emphysema, have a history of recurring lung problems, are almost always long-term smokers, consistently produce sputum, have a chronic cough, have difficulty expelling air from their lungs, and experience long expiration phases and wheezing. Patients with acute COPD will complain of shortness of breath with gradually increasing symptoms over a period of days, exhale through pursed lips, complain of tightness in the chest and constant fatigue, and have a chest with a barrel-like appearance. This figure shows how repeated episodes of irritation and inflammation in the alveoli result in the obstruction, scarring, and some dilation of the alveolar sac, characteristic of chronic obstructive pulmonary disease. Figure A is a normal alveolus. Figure B is infection-produced mucus and swelling. And C is a mucus plug, creates an obstruction and further dilation of the alveolus. Asthma is acute spasm of bronchioles associated with excess mucus production and bronchial muscle spasm. It is common but a serious condition. It's caused by a combination of bronchospasm, mucus production, and edema. Status asthmaticus is a severe prolonged attack. It cannot be resolved with conventional treatment, and it is a dire medical emergency. Wheezing is heard when asthma patients exhale. Breathing appears relatively normal. It results from allergic reactions, exercise, severe emotional stress, and upper respiratory infection. Most patients are familiar with their symptoms and will have an appropriate medication. Listen carefully to these patients. They often know exactly what they need. Anaphylactic reactions are severe allergic reactions characterized by airway swelling, dilation of blood vessels all over the body, significantly lowers blood pressure. It is sometimes called anaphylactic shock. It can cause respiratory distress severe enough to lead to coma and death. It may be associated with widespread itching and an asthma-like condition. Most reactions occur within 30 minutes of exposure to an allergen. Spontaneous pneumothorax is accumulation of air in the pleural space, may be partial or complete. Trauma is the most common cause. It may also be caused by medical conditions referred to as a spontaneous pneumothorax. It may occur in patients with certain chronic lung infections, who are young and were born with weak areas of the lung, who have emphysema, or who have asthma. Tall, thin, healthy males are also at risk. Patients become acutely dyspneic and typically complain of pleuritic chest pain. They have sharp, stabbing pain on one side, worse during breathing or with certain movements of the chest wall. Patients may present with subcutaneous emphysema, air bubbles trapped under the skin. By listening to the chest with a stethoscope, you may note that breath sounds are absent or decreased on the affected side. Patients experiencing minor problems may be pale, diaphoretic, tachypneic. Severe findings include altered mental status, cyanosis, tachycardia, unilaterally decreased breath sounds, local hyperresonance to percussion, subcutaneous emphysema, or tracheal deviation. That is a late sign. Patients with symptoms including severe episodes require immediate care to survive. Pleural effusion is a collection of fluid outside the lung on one or both sides of the chest. By compressing the lungs, the fluid causes dyspnea. Fluid may be from irritation, infection, or cancer. It can build up gradually, but patients often report sudden dyspnea. This should be considered in patients with lung cancer and shortness of breath. When you listen with a stethoscope to the chest of a patient with dyspnea resulting from pleural effusions, you will hear decreased breath sounds over the region of the chest where fluid has moved the lung away from the chest wall. Patients usually feel better when they sit upright. Definitive treatment is fluid removal. This must be performed by a physician. A pulmonary embolism An embolus is anything in the circulatory system that travels to a distant site where it lodges, creating a perfusion disorder by obstructing distal blood flow to that area. It can be fragments of blood clots or foreign bodies. Pulmonary embolism is a blood clot or a thrombus, usually formed in a vein in the legs or pelvis. Then it breaks off, circulates through the venous system, and moves through the right side of the heart and into the pulmonary artery. It decreases or completely blocks blood flow. No gas exchange occurs in areas of blocked blood flow, even though inhalation and exhalation are occurring. It causes ventilation perfusion mismatch. It may also occur as the result of damage to the lining of vessels, hypercoagulability, slow blood flow in a lower extremity. Risk factors include immobilized legs following surgery or fracture, recent surgery, pregnancy, oral contraceptives, infection, cancer, sickle cell anemia, prolonged inactivity, or being bedridden. Signs and symptoms include dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, and hemoptysis, which is coughing up blood. Obstruction of the airway. The patient with dyspnea may have a mechanical obstruction. Be prepared to treat it quickly. In an unresponsive patient, this may be the result of vomitus, foreign object, or improper positioning of the head so the tongue is blocking the airway. Always consider upper airway obstruction from a foreign body first in patients who are eating just before becoming short of breath. Environmental and industrial exposure. Potentially toxic substances can be inhaled, often at industrial sites. These include pesticides, cleaning solutions, chemicals, chlorine, and carbon monoxide. The amount of damage largely depends on the water solubility of the toxic gas. Highly water-soluble gases such as ammonia will react with the moist mucous membranes of the upper airway and cause swelling and irritation. Less water-soluble gases such as phosgene and nitrogen dioxide may get deep into the lower airway where they may cause pulmonary edema up to 24 hours later. Cystic fibrosis is a genetic disorder. It affects the lungs and digestive systems. It is caused by a defective gene that makes it difficult for chloride to move through cells. It causes unusually high sodium loss and abnormally thick mucus secretions. Secretions in the lungs cause breathing problems and infections and leads to lung disease. Symptoms range from sinus congestion to wheezing and asthma-like complaints. Look out for respiratory insufficiency, signs of a respiratory infection, and intestinal blockage. It often causes death in childhood because of chronic pneumonia secondary to thick pathologic mucus in the airway. Age-related conditions. Bronchiolitis. This is inflammation of the bronchioles in the lower respiratory tract due to viral infection. It is caused by metapneumovirus and respiratory syncytial virus, or RSV. It primarily affects infants and children younger than 2 years of age. Signs and symptoms are similar to asthma. Asthma is rare in children younger than 1 year. Infants with first-time wheezing episode in late fall or winter likely has bronchiolitis. RSV is the common cause of illness in young children. It creates an infection in the lungs and breathing passages, can cause severe respiratory illnesses such as bronchiolitis and pneumonia. It is highly contagious and spreads through droplets of a cough or sneeze, and it can survive on surfaces including hands and clothing. Croup is due to inflammation and swelling of the pharynx, larynx, and trachea. It is often secondary to acute viral infection of the upper respiratory tract, typically seen in children ages 6 months to 3 years. Easily passed between children. Starts with a cold, cough, and low-grade fever that develops over 2 days. Hallmark signs are stridor and a seal bark cough. Peak seasonal outbreaks in late fall and early winter. It is rarely seen in adults and often responds well to humidified oxygen. Epiglottitis is a serious inflammation of the epiglottis. It's usually caused by a bacterial infection that produces severe swelling of the flap over the larynx. It is predominant in children but may occur at any age. Development of a childhood vaccine against Haemophilus influenza has dramatically decreased the incidence of this disease. It may completely obstruct the airway. Patients will look very sick, usually has a sudden onset. Patients will usually be in the tripod position and drooling. Symptoms include sore throat, high fever, stridor, and a high-pitched inspiratory sound. It may appear in adults or geriatric patients, especially with other issues such as diabetes. It is caused by different bacterial or viral organisms, can be potentially life-threatening. Deterioration can occur quickly. Pneumonia is a ventilation disorder caused by an infection of the lung parenchyma. It is the 8th leading cause of death in the United States. A group of specific infections, not a single disease. At most risk are very young children and the elderly. Presents as a localized infection in the lungs that may cause atelectasis. If left untreated, it can become systemic, leading to sepsis and septic shock. Signs and symptoms include acute onset of fever and chills, productive cough with purulent sputum, pleuritic chest pain, and excessive mucus causing pulmonary consolidation. Pertussis is an airborne bacterial infection, mostly affects children younger than 6 years. It is highly contagious, passed through droplet infection. They are feverish with a whoop sound on inspiration after a coughing attack. Cold-like symptoms, but coughing spells can last for more than a minute. Child may turn red or purple. Frightened parents may often call 911. Airway obstruction. Always consider the possibility of a foreign body when a young child becomes short of breath, especially crawling babies. Tonsil inflammation may also partially occlude the airway. Dysfunction of a tracheostomy may also create an upper airway obstruction. Obstruction may be in the lower airway below the vocal cords. Trauma to trachea may result in an injury that obstructs the lower airway. It could be from lung disease. It could also be from mucus accumulation or due to a smooth muscle spasm. Edema may also be present when a patient has been exposed to toxic chemicals or superheated air. Heart failure, heart muscles injured by the heart attack or other illness. The heart is not able to maintain cardiac output that meets the needs of the body. It results in pulmonary edema. Risk factors include hypertension, history of coronary artery disease, and or atrial fibrillation. Signs and symptoms include difficulty breathing with exertion, sudden attack of respiratory distress, coughing, feeling suffocated, cold sweats, or tachycardia. Wet lungs versus dry lungs and cardiac asthma. Wet lungs are associated with pulmonary edema. Dry lungs are associated with COPD. Table 17.6 in the text compares the differences between COPD and congestive heart failure. Breath sounds are helpful but can also be confusing. Patients with COPD wheeze, have progressively worsening breathing over time. Most have trouble breathing on exertion, chronic coughing, and thick sputum. They do not have jugular vein distension or dependent edema. They usually are long-term smokers with a thin barrel chest appearance. Medications may include home oxygen, bronchodilators, and corticosteroids. They have a slower onset of symptoms. Patients with heart failure have elevated blood pressure, pedal edema, and history of heart failure, no history of smoking. Do not assume that all COPD patients have wheezing and all heart failure patients have crackles. Treat the patient, not the breath sounds. Patient assessment. Assessment should be calm and systematic. Patients in respiratory distress are usually quite anxious. They may be some of the most ill and challenging patients you encounter. For your scene size up, scene safety, your first thoughts should be standard precautions and PPE. Ensure a safe environment. If necessary, personnel with specialized training and equipment should remove the patient if he or she is in a hazardous environment. Determine the number of patients and whether or not you need specialized resources. Consider the possibility of an airborne hazardous material release. The nature of illness. If the nature of illness is in question, ask why 911 was activated. Your primary survey. Recognition of life threats and initiation of resuscitation take priority over performing a detailed assessment. Sign of life threats with respiratory distress in adults from most to least severe is altered mental status, severe cyanosis, absent or abnormal breath sounds, audible stridor, 1 to 2 word dyspnea, coughing, tachycardia of more than 130 beats per minute, abdominal breathing, change in respiratory rate or rhythm, pallor and diaphoresis, the presence of retractions and or the use of accessory muscles, and tripod positioning. Note your general impression of the patient. If the patient is alert or responding to verbal stimuli, you know that the brain is still receiving oxygen. If the patient is responsive only to painful stimuli or unresponsive, the brain may not be oxygenating well and the potential for an airway or breathing problem is more likely. If there is no gag or cough reflex, you need to immediately assess the patient's airway status. Airway and breathing. Determine if airway is open and clear. Determine if the patient is breathing. Provide the appropriate oxygen therapy for a patient with spontaneous breathing or immediately provide positive pressure ventilations for one who is apneic. If ventilating, determine if ventilations are effective. After assessing breath sounds, evaluate circulation. Assess the pulse, rate, rhythm, and character. Tachycardia or bradycardia indicates the patient may not be getting enough oxygen. Assess for the presence of shock and bleeding. Identify any life threats in your patient by the following signs and symptoms: problems with airway, breathing, and circulation, poor initial general impression, and altered mental status, potential hypoperfusion or shock, chest pain associated with low blood pressure, severe pain anywhere, excessive bleeding. If the patient's condition is unstable and there is a possible life threat, address the life threat and proceed with rapid transport. If the patient's condition is stable and there's no life threats, you may decide to perform a thorough secondary assessment on scene after obtaining the patient history. Assessing breath sounds. Auscultating breath sounds or lung sounds is one of the most important vital signs for your patient in respiratory distress. Lung or breath sounds is one of the most important vital signs for your patient if he or she is in respiratory distress. Listen over the bare chest. Diaphragm of the stethoscope must be in firm contact with the skin, and bring your patient into a sitting position. That figure there indicates where you should listen for the breath sounds at. You need to determine whether your patient's breath sounds are normal or abnormal. Vesicular breath sounds represent air moving in and out of the alveoli. Bronchial breath sounds represent air moving through the bronchi. Adventitious breath sounds are decreased, absent, or abnormal. Listen for a full respiratory cycle. When assessing for fluid collection, pay special attention to the lower lung fields. You want to hear clear flow of air in both lungs. Lack of air movement is a significant finding. Do not confuse absent and clear breath sounds. Table 17.7 in the text provides examples of breath sounds, the diseases that may be associated with them, and important signs and symptoms. Abnormal breath sounds include crackles, fine crackling sounds of air trying to pass through fluid in the alveoli together, and snoring sounds are indicative of a partial upper airway obstruction. If you're having trouble with these breath sounds, crackles is also called rails sometimes, depending on how long people have been in the field. So If you take your hair in between your index and your thumb, put it by your ear and just rub your hair between your fingers, that gives you kind of a sound of what you'll hear when you're listening to crackles or rails. Bronchi is just a congestion in the lungs. Often it can be cleared by the patient coughing. So if their lungs sound congested and you ask them to cough, and that clears, that's bronchi. Um, the stridor, I'm sure all of you know what wheezing sounds like. Stridor's a little bit harder for some people. Pleural friction rubs. Um, YouTube, if you Google breath sounds, they have a lot of medical field videos that actually have recordings of each of these sounds so that you can hear it instead of me telling you what they sound like and describing it, because that's kind of hard to picture or hear in your head. YouTube does have some really good actually live recordings of those breath sounds. So I would suggest that you do listen to those so you can become familiar with them. History taking. With patients in respiratory distress, the sample history can be obtained from the family or bystanders if they are present. Limit the number of questions to pertinent ones. Y'all, if they're having trouble breathing, don't make them just continue to talk. Be sure to ask the following questions about a patient in respiratory distress. What is the patient's general state of health? Has the patient had any childhood or adult diseases? Have there been any recent surgeries or hospitalizations? Have there been any traumatic injuries? And is there any dyspnea or chest pain? If time allows, also ask about the patient's immunization history. Ask about previous episodes, medication allergies, and current medications. If the patient's the patient's subjective description of the problem is an accurate indicator of the acuity of this episode if the disease is chronic. Find out what the patient has already done for the breathing problem. Pay close attention to the medications the patient is currently taking. If medical control permits, you may administer a bronchodilator via nebulizer. You need to reassess breathing frequently and be prepared to assist ventilation in severe cases. Find out whether the patient has any allergies or history of medication reactions. Use the OPQRST-I mnemonic to determine the specifics of pain and obtain specific information about the breathing problem. When did the breathing problem begin? That's your onset. What makes the breathing difficulty worse or better? That's provocation or palliation. How does the breathing feel? That's quality. Does the discomfort move? Radiation and region. How much of a problem is the patient having? That's the severity. Is the problem continuous or intermittent? That's the I. What has been done to alleviate the problem prior to EMS arrival? Does the patient have a cough? Is it productive or non-productive? If it is productive, what color is the sputum? Why does that matter? So pink, frothy sputum, that's indicating congestive heart failure. A green, yellow sputum, that's indicating pneumonia. So that's why we ask about the color. Is there any hemoptysis, wheezing, fever, chills? What is hemoptysis? Hemo, blood, tussis, cough, hemoptysis, coughing up blood. Any increased sputum production? Has there been any exposure to smoke, or does the patient have a history of smoking? Chronic respiratory conditions. Patients with chronic conditions may have long periods in which they are able to live relatively normal lives, but then sometimes experience acute worsening of their conditions. Chronic lower airway obstruction makes it difficult for patients to breathe deeply enough to clear the lungs. If a new infection of the lung occurs in a patient with COPD, the arterial oxygen level may fall rapidly. Patients with COPD usually have a long history of dyspnea with a sudden increase in shortness of breath. They rarely have a history of chest pain. The pulse is rapid and occasionally irregular. Pay attention to the respirations. Patients with asthma may have different triggers. It is important to try to determine what may have triggered the attack so that it can be treated appropriately. Patients with heart failure often walk a fine line between compensating for their diminished cardiac capacity and decompensating. Your history taking should include obtaining a list of all of their medications and paying special attention to the events leading up to the current problem. Secondary assessment, more in-depth assessment of the body systems, addresses specific chief complaint, includes physical examination and taking vital signs. Perform after identifying and treating life threats. Never compromise assessment and treatment of breathing problems to conduct a physical examination. Keep an open mind, gather as complete a history as possible, and perform a physical examination. Physical examinations may reveal additional pieces to the assessment and treatment puzzle. They may provide you with some clues. Conduct an in-depth assessment when the patient complains of shortness of breath. A change in mental status is one of the early warning signs of respiratory inadequacy and indicates a lack of perfusion to the brain. Look for overall symmetry of the chest, adequate rise and fall of the chest, and evidence of retractions or accessory muscle use. Check the patient's respiratory status. Slowing respiratory rate in the face of an unimproved condition suggests physical exhaustion and impending respiratory failure. Respiratory patterns are listed in Table 17.8. Look for signs of increased work of breathing. Many smokers and people with chronic respiratory diseases cough up sputum every day, so determine if the color or amount of this sputum has changed. Table 17.9 in your book lists the types of sputum and the causes. Secondary assessment of the cardiovascular system should include checking and comparing distal pulses, reassessing the skin condition, be alert for bradycardia and tachycardia, check for any signs of trauma or retractions in the chest. A barrel chest indicates the presence of long-standing COPD. Numbness, tingling, and carpopedal spasms may be associated with hypocapnia, resulting from periods of rapid, deep respiration. Blood pressure should be auscultated when possible to obtain a systolic and diastolic measurement. If you are in an environment where you cannot hear well enough to auscultate the blood pressure, then palpation by feeling is an alternative. It is preferable to auscultate when you can because palpation does not provide a diastolic value that may be pertinent when a patient has a condition such as hypertension. Feel for the skin temperature and look for color changes in the extremities and in the core of the body. Cyanosis is an ominous sign that requires immediate aggressive intervention. It's important to assess the neurologic system frequently. Check the patient's mental status and determine if the patient's activity can be described by anxious or restlessness. Monitoring devices, use them if they're available. A pulse oximeter is a non-invasive device that measures the percentage of a patient's hemoglobin that has oxygen attached to it. The pulse oximetry readings may be inaccurate in the presence of conditions that abnormally bind hemoglobin. Diagnostic testing provides a baseline and indicates the severity of respiratory difficulty. End-tidal carbon dioxide, or EtCO2 monitoring, measures the amount of exhaled carbon dioxide. This is accomplished with a device that measures the amount of carbon dioxide exhaled during a specific time and plots the resulting values graphically as a waveform, as well as giving a numeric readout. Exact percentage of carbon dioxide contained in the last few milliliters of the patient's exhaled air can be measured using a special sensor. Peak flow meter provides a baseline assessment of expiratory airflow for patients with obstructive lung disease. Reassessment, repeat primary survey and maintain an open airway, monitor patient's breathing, reassess circulation, determine if there have been any changes in the patient's condition, confirm the adequacy of interventions and patient status. If the changes you find are improvements, continue the treatments. Be prepared to modify treatments if the patient's condition deteriorates. Be prepared to assist ventilations with a BVM. Monitor skin color and temperature. Reassess and record vital signs at least every 5 minutes for an unstable patient and or after the patient uses an inhaler, and at least every 15 minutes for a stable patient with no life threats. Emergency medical care, perform standard interventions, oxygen to keep the saturation above 94%, and an IV line are typical interventions. Psychological support is an important consideration for a patient with dyspnea. Speak with assurance and assume a calm, professional, and caring demeanor to reassure the patient. Decrease the work of breathing. Muscles must work harder during respiratory distress. Tremendous workload uses large amounts of energy, which requires even more oxygen and ventilation. At some point, the patient will tire and be unable to continue the necessary work of breathing. Some patients with asthma may compensate for days, hoping that their steroids and bronchodilators will resolve an attack. Supine position, with or without the legs raised, especially for an overweight patient, causes the abdominal organs to compress the diaphragm. Abdominal distension with air or blood compounds the situation. Remove constricting clothing, such as belts and tight collars, from the patient. Do not make the person walk. Provide supplemental oxygen. This is essential to provide supplemental oxygen to any patient who needs it. Administer oxygen in the concentrations necessary to be effective. Patients who are not breathing adequately should receive bag mask ventilation with supplemental oxygen or more advanced airway management techniques. Pulse oximetry is a useful guide to oxygenation if it is accurate. It is safe to administer oxygen concentrations less than 50% to almost anyone. Oxygen concentrations higher than 50% should be reserved for patients with hypoxia that does not respond to lower concentrations. Use of 100% oxygen should be limited to the shortest period necessary. Never hesitate to administer oxygen aggressively to those patients who need it. Oxygen saturation of 100 should be avoided. Consider the possibility that the pulse oximeter may provide falsely elevated assessment of the patient's overall level of oxygenation. In the context of very short transport times, less than an hour, there is essentially no danger to hyperoxia, and oxygen therapy should be employed liberally. Administer a bronchodilator. Patients who do not have bronchospasms usually benefit only slightly from aerosol bronchodilators. Bronchodilators are of little value in treating conditions such as pneumonia, pulmonary edema, and heart disease. Respiratory medications. Most common medications used for dyspnea are called inhaled beta agonists. Typical trade names are Proventil, Ventolin, Alpuent, Metaprel, and Brethine. Actions of most of these medications is to relax the smooth muscles within the bronchioles of the lungs. Bronchodilators relax the smooth muscle around the larger bronchi and are an important therapy for bronchoconstriction. Fast-acting bronchodilators provide almost instant relief. Bronchodilators do not reduce swelling, kill bacteria, push fluid out of the lungs, or open closed alveoli. Secondary bronchoconstriction could be reversed with a bronchodilator. Medication specifically designed for aerosol use, ipratropium, is available in a metered dose inhaler or an MDI. Anticholinergics have emerged as a central component in the management of COPD. Table 1710 lists medications used for acute and chronic respiratory symptoms. Common side effects of inhalers used for acute shortness of breath include increased pulse rate, nervousness, and muscle tremors. Aerosol therapy, a simple method of delivering medications such as bronchodilators. Aerosol nebulizers deliver liquid medications in the form of a fine mist. To generate the optimal particle size, most nebulizers need to have gas or oxygen flow of at least 6 liters per minute. A nebulizer can be attached to a mouthpiece or pipe, a face mask, or a tracheostomy collar, or it can simply be held in front of the patient's face. The smaller the amount of mist the patient inhales, the less medication he or she receives. Blow-by and mouthpiece treatments are ineffective if patients continually turn their heads or remove the mouthpiece to answer questions. A quick way to provide a cooling mist in the swollen upper airway of a patient with burns or a child with croup is to give an aerosol treatment of saline solution or sterile water. It is possible to give repeated treatments to patients with bronchospasms. Tachycardia is almost always already present in patients with dyspnea, so be sure to consult medical control or local protocols for guidance. Metered dose inhalers are miniature spray canisters used to direct medication through the mouth and into the lungs. They are small and easy for patients to carry and use, and also convenient. Usually the delivery method of choice for bronchodilators and corticosteroids in the home setting. Document how often the patient has been taking an extra puff. Each MDI on the ambulance should be ideally equipped with a spacer. The spacer is a device that collects the medication as it is released from the canister, allowing more to be delivered to the lungs and less to be lost to the environment. Achieving the proper technique when using an MDI requires constant reinforcement. Steps to ensure while administering an MDI. The mist from an MDI must enter the lungs. Some patients mistakenly blow into the spacer. Many spacers make a harmonica-like sound if the patient sucks too hard. Patients should try to inhale the medication deeply and then hold their breath for a few seconds. Make sure the inhaler contains medication. Keep the spacer and canister holder clean. After using a corticosteroid inhaler, patients should rinse out the mouth with water or mouthwash. Contraindications for use of MDI include the patient is unable to help coordinate inhalation with depression of the trigger on the MDI, or is too confused to effectively administer medication through a small volume nebulizer. The MDI or small volume nebulizer is not prescribed for this patient. You did not obtain permission for medical control, and or it is not permissible by local protocol. The patient has already met the maximum prescribed dose before your arrival. The medication is expired. There are other contraindications specific to the medication. About 5 minutes after the patient uses an inhaler, repeat the vital signs and the primary survey. Look at the patient's chest to see whether the patient is still using accessory muscles to breathe. Transport the patient to the closest, most appropriate emergency department. While en route, continue to assess the patient's breathing. Using MDIs as well as administering nebulized treatments may be done en route. Dry powder inhalers. Each time the device is opened, a small plastic blister that holds a dose is rotated into position. The patient then pushes a small lever to puncture the blister, presses the disc to his or her lips over the opening, and inhales deeply to suck the powder out of the device. It is reasonably convenient and easy to use. It is rarely used during emergency care. Consider fluid balance. Common practice to give a fluid bolus to younger patients with these conditions. In any older patient or other patient with cardiac dysfunction, administering too much fluid could cause pulmonary edema. Always assess breath sounds before and after giving a fluid bolus to make certain the patient does not become overhydrated. Support or assist ventilation. If the patient becomes fatigued, breathing might need to be supported more aggressively. Some patients may simply require BVM for a short period of time. Trying to assist breathing for a patient who is already breathing on his or her own is one of the most difficult interventions. It is important to be confident in your bag mask ventilation technique. Gastric distension and vomiting from over-aggressive ventilation can complicate an already worsening situation. Continuous positive airway pressure, or CPAP, is used to treat obstructive sleep apnea and treat respiratory failure. Many people with obstructive sleep apnea wear a CPAP unit at night to maintain their airways during sleep. This type of CPAP may be applied via nasal pillows, a nasal mask, a face mask that resembles a typical mask used for bag mask ventilation, or a mask that covers the entire face. It is not the same type used for critically ill patients. The CPAP used as therapy for respiratory failure is almost always delivered through a mask that is secured to the face by some type of strap. Positive pressure ventilation with a bag mask ventilation or a pocket mask is physiologically the opposite of normal negative pressure ventilation. Using a bag mask device for ventilation produces positive pressure in the chest. Pre-hospital providers have begun to understand the ramifications of positive pressure ventilation during low flow states such as shock and cardiac arrest. CPR is based on principles of hemodynamics, and the rate, volume, and pressure of delivered breaths can quickly do more harm than good during resuscitation. If the patient's blood pressure is already low, too much CPAP can stop venous return to the heart and cause a sudden decrease in blood pressure. CPAP can turn a simple pneumothorax into a tension pneumothorax in only a few breaths. Be vigilant about monitoring the gas supply. Don't struggle with a patient who is unwilling to use the mask. Critical to recognize a deteriorating condition and be prepared to move to the next step. The success of CPAP is inversely related to the patient's respiratory rate soon after its application. If the rate increases, the therapy is likely to fail. If the rate decreases, the therapy is likely to succeed. Bi-level positive airway pressure, or a BiPAP. One pressure can be delivered during inspiration and a different pressure can be delivered during exhalation. It is more comfortable. It causes a pressure variant in the chest, which allows for more normal blood flow. It is more complex and expensive. Assessment and management of specific conditions, upper or lower airway diseases. Patients with obstructive airway disease typically present with signs of severe respiratory impairment. It may include 1 to 2 word dyspnea, diminished or absent breath sounds, altered mental status. The chief complaint is typically dyspnea, cough, or nocturnal dyspnea. That's difficulty breathing at night. Obtain a thorough history, including personal or family history of asthma and allergies. Determine whether the patient has had acute exposure to pulmonary irritant or previous similar episodes. Ask the patient if he or she has ever been intubated. Wheezing may be present. Look for retractions and the use of accessory muscles. Use a peak flow meter to establish the baseline expiratory airflow and pulse oximeter to document the degree of hypoxemia and response to therapy. Place the patient in a position of comfort. Consider calling early for a paramedic if one is available and the patient is in severe distress. Monitor airway, apply high flow oxygen, and assist ventilation if needed. Use humidified oxygen if available. Establish IV access and provide circulatory support. Assist the patient with an MDI as needed. Continue monitoring. Transport to closest appropriate facility. Contact medical control for further orders and provide psychological support en route to the hospital. Acute pulmonary edema may be associated with cardiac disease or direct lung damage. Administer 100% oxygen. If necessary, carefully suction any secretions from the airway. Place the patient in position of comfort. Provide assisted ventilation. Continuous positive airway pressure has proven immensely beneficial. Establish IV access. Monitor flow rates carefully. Consider calling paramedic backup for intubation and transport promptly. Aspiration is inhalation of anything other than gases. Patients who receive tube feedings are at particular risk for aspiration if they are placed supine immediately after receiving a large feeding. Aspiration is associated with a high mortality rate. It is a dangerous complication in patients who have had cardiac arrest and in patients who are unresponsive as a result of trauma or overdose. The aspiration of stomach contents carries the additional risk of aspiration pneumonitis, in which the gastric acid irritates lung tissue. Chronic aspiration of food is also a common cause of pneumonia in older patients. When treating patients at a risk for aspirations or who have aspirated, aggressively reduce the risk of aspiration by avoiding gastric distension while ventilating. Aggressively monitor the patient's ability to protect his or her own airway and protect the patient's airway with an advanced airway when needed. Aggressively treat aspiration with suction and airway control if the previous steps fail. COPD, patients may have an altered level of consciousness. Patients often find breathing difficult while lying down. Assist with prescribed inhaler if there is one. Patients with COPD will often overuse an inhaler, so watch for side effects. Transport as promptly as possible to the emergency department, allowing the patient to sit upright if that is the most comfortable. Auto PEEP, not everyone should be ventilated the same way. Remember the difficulty in exhaling. Complete exhalation must be allowed before the next breath is delivered. This can eventually cause a pneumothorax or cardiac arrest. Patients in whom auto PEEP is a concern should be ventilated at a rate as little as 4 to 6 breaths a minute. Asthma. Many lung problems are incorrectly labeled as asthma. Your assessment of the patient is critical. Often a recurring pathologic condition. Confirm whether the patient is able to breathe normally at other times. If possible, ask family members to describe the patient's asthma. 3 components of asthma are bronchospasm, airway edema, and increased mucus production. Air is trapped in the distal portions of the lung and does not allow air from the next inhalation to enter the alveoli. As you assess vital signs, note that the pulse rate will be normal or elevated, the blood pressure may be slightly elevated, and respirations will be increased. Ask questions about when and how the symptoms began. Bronchial asthma is characterized by an increased reactivity of the trachea and bronchi to a variety of stimuli. Is a common childhood illness. Look for retractions of skin above the sternum and between the ribs when assessing a pediatric patient. Cyanosis is a late finding, and be alert for coughs. Be prepared to suction and administer oxygen. Allow some time for oxygenation between suction attempts. If the patient is unresponsive, you may have to provide airway management. If the patient has medication, help administer inhaler or nebulized medication as directed by local protocol. Even patients who use their inhaler may continue to get worse. Reassess breathing frequently and be prepared to assist ventilations in severe cases. If you must assist ventilations, use slow, gentle breaths. Remember, in the case of asthma, the problem is getting air out of the lungs, not into them. Resist the temptation to squeeze the back hard and fast. Always assist with ventilations as a last resort. Emergency care of a child is the same as for an adult, including the use of supplemental oxygen. Many small children will not tolerate a face mask. Hold the mask for them or ask a parent to assist. Administering a treatment with a bronchodilator may stabilize the event. Status asthmaticus is a dire medical emergency. The chest will be maximally hyperinflated. Breath sounds and wheezes may be entirely inaudible because air movement is negligible. The patient may be exhausted by the time you reach the hospital. They may have stopped feeling anxious or struggling to breathe. If this is the case, the patient is likely to stop breathing. Aggressive airway management, oxygen administration, and prompt transport are essential. Consider advanced life support and follow local protocol. Anaphylactic reactions. First, remove the offending agent. Maintain the airway. The airway is always priority regardless of the situation. If the patient is still awake, allow him or her to assume a position that does not compromise breathing. Administer supplemental oxygen using an appropriate device and consider early transport. Assist breathing as needed. Epinephrine is treatment of choice. Management of anaphylaxis is covered in detail in Chapter 22 under the immunological responses. Spontaneous pneumothorax. The management begins with ABCs, provide airway and ventilatory support, including high-flow oxygen and assisting ventilation as needed. Be alert for signs of the development of tension pneumos. Consider IV initiation if severe patient symptoms are present. Pharmacologic interventions are not typically necessary. Place the patient in a position of comfort. Transport to the closest appropriate facility. The patient's condition should dictate transport mode. Provide reassurance en route. Consider calling for a paramedic unit if the patient shows signs of developing a tension pneumothorax. Pleural effusion. Treatment is removal of fluid collected outside of the lung. It must be done by a physician in the hospital. Provide oxygen and other routine support measures and transport. Pulmonary embolism. Manage the airway and provide high flow oxygen. Assist ventilations as needed. Initiate CPR for pulseless and apneic patients. Establish an IV of an isotonic crystalloid solution. Give fluid for hydration based on clinical symptoms. Other interventions are supportive. Manage most severe cases as cardiac arrest of unknown origin. Transport in appropriate mode to appropriate facility. Offer reassurance and psychological support en route. Call for paramedic backup if needed. Hyperventilation can be caused by life-threatening illness or panic attack. Determination of which it is should not be made outside of the hospital. Give supplemental oxygen and transport. Management depends on cause. Never withhold oxygen from any patient complaining of dyspnea. Factors such as carbon monoxide toxicity may produce a falsely high oxygen saturation reading. If a patient's history confirms anxiety-related hyperventilation, consider coached ventilation. When in doubt, provide 100% oxygen. Interventions for circulatory support and pharmacologic interventions are rarely required. Provide psychological support for anxiety-related hyperventilation. Have the patient mimic your respiratory rate and volume. Never place a paper bag over the patient's mouth and nose. And provide transport to the closest appropriate facility. The patient's condition dictates the transport mode. Obstruction of the airway. If the patient is a small child or someone who was eating just before dyspnea developed, you may assume the problem is an inhaled or aspirated foreign body. If the patient is old enough to talk but cannot make noise, the upper airway obstruction is the likely cause. Upper airway obstruction may be either partial or complete. If the patient can talk and breathe, it may be best to provide supplemental oxygen and transport in position of comfort. There is no condition more immediately life-threatening than a complete airway obstruction. Remove the obstructing body according to basic life support guidelines. Head tilt chin lift maneuver may solve the problem. Perform only after you have ruled out a head or neck injury. If opening the airway does not correct the problem, assess the airway for obstruction. Whether or not you are able to clear the airway, administer supplemental oxygen, and transport the patient promptly to the emergency department. Environmental industrial exposure. Industrial sites often have their own medical fire or hazmat teams. They will begin immediate decontamination and medical care. In these cases, the patient must be decontaminated by trained responders before you take responsibility. Once the patient is decontaminated, gather information on substance and cause of dyspnea. Assess the patient, paying special attention to lung sounds. Blood coming from the airway is an ominous sign. Provide 100% supplemental oxygen or assisted ventilations if necessary. If the upper airway is compromised, aggressive airway management may be required. Age-related assessment management, bronchiolitis. Treatment of infants and young children is entirely supportive. Leave the patient in a position of comfort. Provide supplemental oxygen. Be prepared to assist with a BVM. Call for paramedic backup for endotracheal intubation if needed. RSV, look for signs of dehydration. Infants with RSV often refuse liquids and become dehydrated. Treat the airway and breathing problems as appropriate. Humidified oxygen is helpful if available. For croup, this often responds well to humidified oxygen. Allow the patient to assume position of comfort. Avoid agitating the patient. Administer nebulized epinephrine if dictated by local protocol. Transport rapidly to the appropriate facility. Epiglottitis, if the patient is a child, be especially gentle. Try not to do anything to make him or her cry. Keep the patient in a position of comfort. Give high flow O2. Do not put anything in the patient's mouth. For an adult patient, focus on maintaining a patent airway. For pneumonia, monitor ABCs, provide high flow oxygen and ventilatory support as needed. Administration of IV fluids may help. If the fever is high, cool the patient down. Transport to closest appropriate facility while providing psychological support. Pertussis, some infants and younger children should be treated in a hospital. They are at greater risk of complications like pneumonia and can sometimes be life-threatening. Children may vomit or not want to eat or drink. Watch for signs of dehydration. Suction is necessary. Give oxygen by the most appropriate means. In adults or geriatric patients, it does not typically cause whooping illness as seen in young children. It can cause severe upper respiratory infection in older patients, which can result in pneumonia. It can cause extremely severe coughing spells that last for weeks. Coughing can lead to cracked ribs. It's easily prevented with a vaccine. Advanced EMTs should check their immunization status and get a booster. Airway obstruction in a young child, especially a crawling baby, consider that the patient may be choking on a small object. Abnormality in voice is one sign of aspiration. Perform the most appropriate airway clearing technique. Provide oxygen and transport. Radiograph will be needed to confirm aspiration, its location, and how to treat it. For heart failure, when patients with heart failure decompensate, they will often experience pulmonary edema. High blood pressure and low cardiac output often trigger this flash. It is sudden pulmonary edema. The patient's pulse will be tachycardic. The patient may have hypertension early, followed by deterioration and hypotension as a late finding. Treatment should consist of airway, ventilatory, and circulatory support. CPAP is often indicated for patients who have moderate to severe respiratory distress from an underlying disease such as pulmonary edema from heart failure or obstructive pulmonary disease and are alert and able to follow commands. Tracheostomy dysfunction. Children with chronic pulmonary medical conditions may use a home ventilator connected by a tracheostomy tube. It is placed in the neck. Complications include obstruction by secretions, mucus or foreign bodies, bleeding, leaking, dislodgement, or infection. Establish a patent airway. Place the patient in position of comfort. Suction to clear the obstruction. And if you are unable to clear the airway, consider paramedic interventions. Once the obstruction is clear, oxygenate the patient and treat based on presentation. Geriatric patients may have a tracheostomy tube in place because of airway obstruction, laryngeal cancer, severe infection, trauma, or the inability to manage secretions. This can be obstructed by secretions, foreign bodies, or airway swelling. The stoma itself can become infected. Establishing airway patency is the immediate goal. Epidemic and pandemic considerations. An epidemic occurs when new cases of a disease occur in a human population and substantially exceed what is expected based on recent experience. A pandemic is an outbreak that occurs on a global scale. The flu pandemic occurs when a new influenza virus emerges for which people have little or no immunity. The disease can spread easily from person to person, cause serious illness, be found in multiple countries in a short time. No specific vaccine immediately is available. The H1N1 strain of influenza type A became a pandemic in 2009. It may make chronic medical conditions worse. All strains of influenza type A are transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by infected people. Many potentially serious diseases can be passed by the respiratory route. Always wear your PPE, gloves, eye protection, and a HEPA respirator at a minimum. Viruses can live for several days on surfaces. Frequent hand washing is important. Maintain your vaccinations and stay up to date on the latest CDC recommendations. Place a surgical mask on patients with suspected or confirmed respiratory disease and wear a HEPA respirator during aerosol generating procedures such as suctioning or CPR. And that is it for chapter 17.